Introduction. The historical development of laparoscopy can be traced back to early 1900s when Georg Kelling from Dresden in Germany performed a celioscopy by inserting a Nitze cystoscope into the abdomen of a living dog after creating a pneumoperitoneum using air. This was the beginning of laparoscopic era. His study on physiology and anatomy together with the knowledge of using gas to insufflate the abdomen was a pioneering achievement that took laparoscopy forward. Hans Christian Jacobius, based on Kelling's experience, performed the first clinical laparoscopy and thoracoscopy in 1910, recognizing the immense diagnostic and therapeutic possibilities of laparoscopic surgery. A century ahead, we are now more technical and technological. With the culmination of technological advances, laparoscopic surgery is ingrained in our surgical practice, and we are able to perform diverse and complex laparoscopic procedures, also termed as minimally invasive surgery. Laparoscopic surgery is defined by its three main components of image production: light source, laparoscope, rod lens system or today's electronic imaging and camera, pneumoperitoneum, the insufflation of carbon dioxide gas to create space for operation, and laparoscopic instruments. With this combination, surgeons could perform diagnostic and some basic gynecological procedures since the 1960s. However, a major revolutionary shift in surgical practice and thinking came in 1988 when Philippe Moret from France performed the first laparoscopic cholecystectomy. Instead of removing the gallbladder through a Coker's incision, he did it through a few small wounds, each not larger than 1 centimeter. This exciting concept sparked intense developments in instrumentation, innovation in advanced technical procedures, proliferation of training programs and setting up of laparoscopic centers. We were indeed at the start of a modern surgery era. Laparoscopic surgery and conventional open surgery are today coexisting and part of repertoire of any surgeons, so all young surgeon in training should develop skills in. This brings us back to the objective of writing this manual for improvement in training and safety in practice. Several procedures are totally being replaced by laparoscopic approach, like cholecystectomy that has replaced the traditional open approach in all gallbladder disease as the new gold standard because it results in less postoperative pain, less postoperative pulmonary dysfunction, faster return of bowel function, shorter length of hospital stay, faster return to normal activities and work, and greater patient satisfaction. These benefits also generally extend to other laparoscopic procedures. The advantages mentioned concludes the most obvious difference between laparoscopic and open surgery, that of less surgical trauma to the wound in laparoscopy. The access scar is minimized, leading to less pain, less wound infection and dehiscence with better cosmetic result. In addition, laparoscopy also reduces tissue trauma during dissection and subsequent blood loss, systemic and immune response and adhesive complications. From the surgeon's point of view, the projected image on the monitor is a magnified image, resulting in better definition of structures. The smaller wounds take shorter duration to close, and the video recorded procedure can be used for review and training purposes. As in all surgical techniques and technologies, minimally invasive surgery also has its limitations and disadvantages. First, one may encounter problems during access into the abdominal cavity, such as iatrogenic injuries to the bowel or major vascular structures. The incidence is about 0.05 to 0.1%. This incidence can be reduced by practicing the open technique of introduction, rather than using the blind Veress needle technique and blunt-tipped trocars. Second, there may be undesirable side effects of carbon dioxide pneumoperitoneum, such as hypercarbia. See chapter on physiology of pneumoperitoneum. And third, from the surgeon's perspective, migration from open to laparoscopic skills means that the 3D vision is reduced to monocular 2D vision on the screen, depth perception and field of view is much reduced, and haptics, or the feel and tactile sensation of tissues, is limited to gross probing of tissues. However, these limitations, once understood and overcome, have not hampered the development of laparoscopy. In a way, the surgeon is required to master a new set of skills to perform laparoscopy safely. With training and experience, surgery can be performed at a new standard that benefits patients. Laparoscopy can now be performed in three main areas of the body: the abdomen, the thorax, and closed spaces. Laparoscopy can be used to resect tissues or to reconstruct tissues. One can see that laparoscopy is widely applied. It is important, however, to realize that for certain conditions laparoscopy is feasible but does not necessarily replace open techniques. The practice will depend on the expertise available and also on literature evidence that laparoscopy is superior to the open approach. Surgical training is the core reason for the conception of this training manual. Surgeons in training are taught well-established skills in open surgery. However, learning of laparoscopic skills is now becoming an increasingly important part of the training program because of the new set of skills that need to be acquired. The main focus is to operate efficiently and minimize surgical errors, i.e., operate safely. Training and constant practice are ways to overcome the learning curve. A case point is the dramatic increase by 3 to 5-fold in bile duct injuries in the early years when laparoscopic cholecystectomy was performed by inexperienced and poorly trained surgeons. The rate has since dropped to acceptable levels. Minimally invasive surgery, as it stands today, has been the result of intense and continuous development and innovation on the part of surgeons in techniques, private industries in instrumentation, and in no small part by public demands and patient requests. Surgical innovation will and should continue, however, while maintaining a balance of not escalating costs of healthcare delivery. The progress of MIS will mirror that of developments in instrumentation because technical innovation and expansion into previously difficult territories and advanced procedures has reached a plateau. With better and newer instruments, procedures can be performed faster and more effectively, with the potential of reducing operating duration and overall costs. With progress in information technology, IT, mass data can be exchanged faster along the Internet and 5G technologies, thus enabling more use of broadcasting and teleproctoring to remote areas. Robotic devices have been developed, and today several devices are in the market ready to be used for all procedures to assist in surgery and may one day also allow surgeons to operate from remote locations. And interconnectivity of information will streamline the process of surgery. In conclusion, laparoscopy is a marriage of surgical skills, surgical innovation, and technology advancements. Training is at the core of improving surgeons so that patients benefit from the high quality of care given to them. Davide Lamanto.